Sorry, there was a mistake. So consider this as the second part of the presentation, which is a continuum, right? All right. So we are in the drugs that affects the renin, angiotensin, aldosterone system. So yeah. So finally, angiotensin 2 is liberated, and that acts on the AT1 receptor and produces vasoconstriction, increase aldosterone release, so that increases the retention of sodium water, and both will increase the blood pressure. And we are also aware of two drug classes that could reduce this activation of angiotensin system. One is angiotensin converting enzyme inhibitor, and the other one is angiotensin receptor blocker. The angiotensin converting enzyme, here you need to know an additional point. Until now we know that angiotensin converting enzyme is involved in the conversion of angiotensin 1 to active angiotensin 2, but it is also involved in inactivating another molecule called bradykinin. In fact, I had asked you in the previous session to Google bradykinin and to see what it does. Right? So those who have done that job would be familiar with the molecule called bradykinin. The angiotensin converting enzyme inactivates bradykinin. So now if you are using angiotensin converting enzyme inhibitors, so they inhibit this ACE enzyme, so thereby what happens to bradykinin? Its level shoots up. So when there is more bradykinin, actually bradykinin is doing good to the patient with hypertension, because more bradykinin causes increased release of nitric oxide in the smooth muscles of blood vessels, as well as it increases the release of prostacyclin, and both are vasodilators. So they compound the effect of blocking angiotensin 2. So this adds to the effect of angiotensin 2, so which is good. So here you need to know that ACE inhibitors have their anti-hypertensive effect mainly by reducing the active angiotensin 2 and thereby reduces the activation of angiotensin 1 receptor. And second, it also, by inhibiting this enzyme, the ACE inhibitors also increases bradykinin levels, and that again leads to vasodilation. So both these are the mechanisms that contribute to its anti-hypertensive effect. This picture is again the same one that we had it in the congestive cardiac failure. In the slide, I think, where we were discussing vasodilators, this picture was there, and at that time I didn't tell you much about this pathway. I told you we'll discuss it during the antihypertensive drugs, and this is the time I wanted you to focus on this entity. So ACE inhibitors, if you see, they prevent the destruction of bradykinin, and thereby they increase nitric oxide production, and thereby they lead to vasodilatation. This is the same one that is there. All the ACE inhibitors, they end with the suffix pril. So whenever you see a drug ending with pril, please keep in mind they all belong to ACE inhibitors. The ones that I have highlighted in the blue are the commonly used ones, or they have some unique features that you need to keep in mind. Captopril, if you see, chemically it belongs to sulfhydryl containing ACE inhibitors. Why is this important? Why, as a clinician, we need to know that captopril has a sulfhydryl group in it? Because we'll be seeing it in a while that the sulfhydryl molecule gives abnormal taste sensation. So because of this, if you are prescribing this to your patients after some time they would feel that they have some abnormal problem because of taking captopril, and they would stop taking this drug because of the altered taste sensation. So they would become non-compliant, their BP will shoot up. So that's why it is always important to ask, if you are prescribed captopril, to follow up the patient on whether any taste disturbance is there, and accordingly you may have to move to one other ACE inhibitors. Apart from captopril, enalapril, lisinopril, ramipril. These are the three commonly used prils, ACE inhibitors in practice. Some of the key characteristics that you may have to keep in mind is, all the ACE inhibitors are prodrugs. A while ago we discussed this. Alpha methyl dopa is a prodrug, right? So all the ACE inhibitors are prodrug except for these three: captopril, lisinopril, and be careful, it is not enalapril, it is enalaprilat, right? Enalapril is still a prodrug. It is not pril here, you would say it is prilat. So enalaprilat, captopril and lisinopril, these are the active drugs as such. They are not prodrugs. Captopril, amongst the orally administered ACE inhibitors, has the highest lipophilicity. So the rate of absorption of captopril is much faster than other orally administered ACE inhibitors. Why is this important? If you have a patient in hypertensive crisis and you are sitting somewhere in the peripheral clinic, you don't have an intravenous drug, you don't have someone to assist and monitor, so you could quickly give oral captopril, and that will immediately get absorbed into systemic circulation, and that is also an active drug, so it doesn't take any time to get converted to active form, unlike other ACE inhibitors which are prodrug. So that could much earlier could control the high blood pressure in such crisis patients. So that is the clinical significance of knowing that captopril has the highest lipophilicity and its rate of absorption from the gastrointestinal tract is the fastest amongst the orally administered ACE inhibitors. And ACE inhibitors, they are mainly excreted by kidneys as such. All ACE inhibitors except fosinopril, spirapril. These are the two ACE inhibitors that undergoes a unique phenomenon called balanced elimination, meaning 50% of these drugs are metabolized by liver and 50% eliminated by kidney unchanged. So this is something which is very rarely seen amongst the armamentarium of drugs that we have in practice. So either the drug is metabolized by liver or the drug will be eliminated by kidneys. But there are only a handful of agents which undergoes such metabolism by liver as well as remaining will be eliminated by kidney unchanged. So one are fosinopril and spirapril. Where do we give ACE inhibitors? In hypertensive patients. If you have individuals less than 55 years old and they don't have any comorbid diseases like diabetes, congestive cardiac failure, nothing, MI, stroke, no comorbid diseases, then ACE inhibitors are considered and recommended to be first line anti-hypertensive drugs. Second, if you have a hypertensive patient with comorbid diabetes, then again ACE inhibitors are the first line agents because patients with diabetes are more likely to develop diabetic nephropathy or diabetic retinopathy. So these are some microvascular complications that occur in diabetic patients when their blood sugar is uncontrolled. So ACE inhibitors are very good in controlling these complications. They delay the occurrence of such microvascular complications like nephropathy and retinopathy, and so we prefer it as the first line drug in a hypertensive patient with concomitant diabetes. Similarly, you have a hypertensive patient with concomitant congestive cardiac failure. Do you think ACE inhibitors should be preferred as one of the first line agents? Why? Yes, they are one of the agents that also reduces cardiac remodeling. Right? Go back to that figure we had, you would see angiotensin 2 also causes remodeling, which worsens the heart failure, and so you may have to give it in patients with heart failure, and the same reason holds true for patients who have prior MI. And lastly, for patients who have chronic kidney disease, who are not on dialysis, they are more likely to have excretion of proteins. Both in diabetes mellitus when they develop diabetic nephropathy as well as in chronic kidney disease patients, they are more likely to have proteinuria, which means there is increased excretion of proteins in their urine, which says there is a damage with the glomerulus. So for both these, again ACE inhibitors are the preferred first line anti-hypertensive drugs. So please nail this important information. When should I start ACE inhibitors as anti-hypertensive drug? Very important, very important. Please store it in the DNA. But before giving ACE inhibitors, you need to do two things. First, you need to find out whether if it is a woman, she is a pregnant or not. If she is pregnant, ACE inhibitors are absolutely contraindicated because they have a high teratogenic potential, so they should never be given in any trimester in pregnancy. You should rule this pregnancy if it is a woman. Second, you should put your stethoscope in the abdomen, close to the umbilical region, paraumbilical region, and then try to look for bruit. If you are not familiar with this word, just do a search, and in YouTube you can also have some videos that says how will a bruit sound like. It's like a water flowing in a in a pipe like that. So this bruit you need to look for before writing ACE inhibitors in the prescription pad. Clinically, you should also order an ultrasound abdomen, specifically asking the radiologist to rule out what is called as renal arterial stenosis. So before starting a patient on ACE inhibitors, you need to do two things. If it's a woman, rule out pregnancy. If it is a woman or a man, right, rule out renal arterial stenosis both by clinical examination and by radiology. Nothing but you could see renal artery stenosis is atherosclerosis of the renal arteries, and that reduces the supply of blood to the kidneys. Especially when it is bilateral, it is a must no for ACE inhibitors. Not only ACE inhibitors, even ARBs, any drug that affects the angiotensin aldosterone system should not be administered in patients with bilateral renal arterial stenosis. When the stenosis is happening in both the sides, that is 100% contraindication. Why? Why should we not give ACE inhibitors in such patients? What is the rationale behind this contraindication? For this, you need to know what is the physiology of angiotensin 2 on the glomerulus of the nephron. I know it's too early for you to know about the basics of nephron, but broadly remember from our previous sessions too. So nephrons are the fundamental units of kidney, and it starts with the glomerulus. Then you have a proximal convoluted tubule, PCT. then you have a loop of Henle, right? Then you have distal convoluted tubule, DCT, collecting duct, right? Right? So, these are the important segments of the nephron. If you consider the glomerulus, where you have the filtration happening, glomerular filtration happening, this is how the picture will look like. You will have an artery that brings, the blood here, and from the blood you have movement of electrolytes, various other molecules like creatinine, urea, uric acid, water, and then the remaining will go into another arteriole. So, the arteriole that brings this blood containing molecules to the glomerulus is called afferent. Afferent is the one that brings the water and the other electrolytes to the glomerulus. This is the glomerulus. And after they are all here, they get filtered, and whatever is remaining they will get collected, and then they move it to another arteriole which is called efferent. Efferent arteriole takes away the remaining blood on the other molecules after they are filtered across the glomerulus. Now, assume you have a patient with renal arterial stenosis. So, in both the kidneys, both the renal arterioles, here we are referring to afferent arterioles, right? They are constricted by the presence of atherosclerotic plaque. So, the lumen is narrowed. When the lumen is narrowed, so the amount of blood that flows through this will be less. So, the amount of water and the sodium that gets filtered across this glomerulus will be less. So, less sodium and water will go. If you know the physiology, less sodium and water filtration will send a stimulus to juxtaglomerular apparatus. Juxta, the word juxta means it's a neighbor, it's close by. That is what the English term juxta means. So, if it is juxtaglomerular apparatus, it means this apparatus is close to the glomerulus. And what does this apparatus do? We have seen it increases renin. When renin is increased, finally you have increased production of angiotensin 2. And what does angiotensin 2 do to the arterial system? Vasoconstriction. So, when there is a reduced blood flow because there is a renal arterial stenosis, there is reduced filtration of sodium and water across glomerulus, this activates the juxtaglomerular apparatus, and that increases renin release, and finally you have increased angiotensin 2 molecule, and this angiotensin 2 constricts the efferent arteriole. You could see here the luminal diameter of the efferent arteriole. It is much smaller than afferent arteriole, right? So, here when you compare this efferent arteriole, it is constricted. So, it undergoes constriction. If you constrict this efferent arteriole, what will happen to the pressure across the glomerulus? It will increase. When the pressure increases, what will happen to the amount of sodium and water that gets filtered? That will increase. So, this is a way of compensation to reduced blood supply in patients with bilateral renal arterial stenosis. Now, if you are using ACE inhibitors in such patients, what will happen? ACE inhibitors or angiotensin receptor blockers or direct renin inhibitors, any drug that affects renin angiotensin aldosterone system, what happens to such patients? Now, you have blocked ACE, you have used ACE inhibitors, so you don't have angiotensin 2, so there won't be any constriction of efferent arteriole. So, the efferent arteriole will remain as like the afferent arteriole, or it can still be larger than afferent arteriole, in which case the pressure will never be corrected here, the pressure will lower here. So, low entry of sodium water, such patients will land up in renal failure. So, this is the reason in not using, in not using ACE inhibitors, and you need to do a prior physical examination and ultrasound examination to rule this out, that the patient doesn't have any bilateral renal arterial stenosis. Unilateral, I think it can be used in unilateral, but definitely in bilateral, ACE inhibitors, ARBs, DRIs, direct renin inhibitors should be avoided. So this you need to keep in mind. What are the other adverse effects that we will see with ACE inhibitors? Another important point that you need to keep in mind is ACE inhibitors, they are more prone to produce what is called as first dose effect, meaning whenever the patient is taking the first dose of, today you have the patient coming to your clinic and you made a diagnosis that the patient is diabetic, hypertensive, so the patient first line drug, anti-hypertensive drug is one of the ACE inhibitors. So you have prescribed lisinopril and then you are sending the patient back home. If you are doing that, you need to give one advice to the patient. See madam, today when you are taking the drug, the first dose tonight, please take it after you completed your dinner. Please take it just before you are going to bed. So after taking dinner, take the droplet and immediately lie down. Don't wake up. Don't go to bathroom. Don't wake up till the morning. So this specific advice has to be given to the patient, because with the first dose of ACE inhibitors, it's more likely that the patient's BP will drop, especially when the patient is more likely to have postural hypotension. So when the patient sits up from the lying down position or stands up from the sitting position, the BP won't be enough to supply blood to the brain. So the patient will fall down. That will cause a lot of catastrophe. So to avoid it, please give this specific advice that the first dose should always be taken in the supine position. After dinner, taking the drug, lie down immediately. Don't wake up in between till the morning. Right? So the specific advice, please keep in mind, as a GP you are supposed to know this. Second important adverse effect is hyperkalemia. Why? Why should the use of ACE inhibitors raise potassium level? Think about it. Yes. Angiotensin 2 increases aldosterone, and aldosterone causes sodium retention but loses potassium. Now what you have done to aldosterone? By using ACE inhibitors, you have reduced aldosterone and that retains potassium, and that leads to hyperkalemia. Why should this be kept in mind? Hyperkalemia is a serious adverse effect that can cause various arrhythmias. And when you are combining one from ACE inhibitor with another from ARBs or another from DRI or spironolactone, if you are using any of these drugs in combination, more is the risk of hyperkalemia, more is the risk of cardiac arrhythmias. So you should always keep this point in mind, that use of ACE inhibitors is likely to raise potassium level, and if you are using a concurrent other drug that has the same side effect, you have to take utmost precaution to avoid that drug or to give at reduced doses. Another important side effect for ACE inhibitors is dry cough. Almost all patients who are on ACE inhibitors, they complain of this dry cough. Why? Yes, that's because if you recollect a while ago, we said ACE inhibitors reduce angiotensin 2 and they also increase bradykinin levels. And this increased bradykinin is responsible for occurrence of dry cough. You need to, if patients complain of dry cough, you need to tell them that if the dry cough is not embarrassing, not severe, you are able to tolerate it, it is better to continue with the ACE inhibitors rather than stopping it and giving it. If the patient says, no doctor, it is very terrible for me, I cannot control even at night, it is disturbing my sleep, then you may have to stop ACE inhibitors and give other drugs that inhibit renin, angiotensin, aldosterone axis. Otherwise, the first thing that you should always do in patients who complain of dry cough with ACE inhibitors is counseling. Counseling, and then tell them that this will reduce over time, and there are some evidences that if you add aspirin, if you add iron supplements, there are evidences that may reduce dry cough, so you could try with that. But tell them, counsel, and then if they're not agreeing, then you don't have a choice, shift to other drugs that block renin, angiotensin, aldosterone axis. Right? And as I told you, captopril, because of the sulfhydryl, they cause altered taste sensation. And other important adverse effects is angioedema. So patients who are receiving ACE inhibitors can land up in having edema of larynx, edema of the lips, severe. They may be life-threatening. So if you have angioedema developing with ACE inhibitors, they should never ever receive any other ACE inhibitors. It's a full stop. They should be immediately stopped of ACE inhibitors, and they should not be put on other ACE inhibitors. They can be given ARBs, they can be given DRA, direct renin inhibitors, but certainly not any other ACE inhibitors. It is an absolute contraindication. And lastly, we discussed it should not be given to a pregnant because of its teratogenic potential. So these are all the important points that you need to keep in mind with regard to ACE inhibitors. When will you start it? What precautions will you take? When will you not start it? What other monitoring will you do while this drug being received by the patient? Moving to the second class in the same drugs affecting renin, angiotensin, aldosterone axis, which is angiotensin receptor blockers. So this drug class prevents the binding of active angiotensin 2 to the AT1 receptor, which mediates vasoconstriction, and thereby by preventing its action on AT1, the ARBs will reduce systemic vascular resistance and blood pressure. Another important difference from ACE inhibitors, apart from this mechanism, is the ARBs, they don't influence bradykinin levels. They don't affect bradykinin in any way. So is this good or bad? Good in one sense that you won't have any dry cough, right? So this will not happen. That is good. But when compared to ACE inhibitors, what do you think the therapeutic efficacy of ARBs will be? ACE inhibitors have dual action. They block AT2 and they also increase bradykinin, which releases nitric oxide. So in terms of anti-hypertensive effect, they have two ways of reducing blood pressure. But when it is concerning to ARBs, it is only the AT1 blockade. They don't have any nitric oxide arm. So it is good and bad both the ways that they don't act in bradykinin. It's bad that they don't have an additional antihypertensive effect. That is why even today, ACE, amongst the drugs that affect angiotensin aldosterone system, ACE are considered to be the first line and not ARBs. ARBs are always the second line. If patients cannot tolerate ACE, then only they are put on ARBs. All the ARBs, they end with sartan. So whenever you have a drug ending with sartan, automatically you could consider that they are angiotensin receptor antagonist. Actually, it is angiotensin receptor antagonist. ANT is TAN, TAN, right? All right. So we have various of these. The commonly used ones are the losartan, telmisartan, valsartan. Telmisartan has something unique I need to tell you. Almost all the ARBs are long acting. If you see, you can give just once a day, including telmisartan. Once a day is enough. So that improves compliance over longer time. Good. Telmisartan has the volume of distribution, maximum volume of distribution, right? So that contributes again to its high action on the blood vessels. Second, telmisartan has, although it is too early for you to know about this, but just make a note, it has agonistic action on peroxisome proliferator activated receptor gamma. So it's a PPAR gamma agonist. So you will encounter this term in management of diabetes mellitus in unit 4. So we have a drug class which modulates this gamma, and thereby it reduces insulin resistance. So it is preferred for patients with diabetes mellitus. So telmisartan has this additional property. It has a dual property of blocking angiotensin receptor and also acting peroxisome proliferator activated receptor. So these are some of the important differences. With regard to the adverse effects, we have seen all adverse effects with ACE inhibitors will be applicable to ARBs except for cough, right? So if you have a patient on ACE inhibitors developing angioedema, right? I told you should not prescribe any other ACE inhibitor, and you should also not prefer angiotensin receptor blocker. In fact, it should not be prescribed any drug that affects renin-angiotensin aldosterone axis. This is one important, although we see it very rarely, important indication, a contraindication that you need to keep in mind, right? But we get to know only when you start a drug, right? So, but keep in mind, should be not given any AC or ARBs. When do we write or when do we prescribe ARBs? Mainly if they are unable to tolerate ACE inhibitors. Predominantly, as I told you, they have a dry cough, it is very embarrassing, they cannot control it, it is disturbing their sleep, they have a poor quality of life because of that, then only you could consider them putting on ARBs. And as like ACE inhibitors, before starting them, you need to do a check for renal arterial stenosis, both physically as well as radiological examination, right? The last category of drugs within the drugs affecting renin-angiotensin aldosterone axis is the direct renin inhibitor. We know ACE inhibitors that affects angiotensin converting enzyme and prevents conversion of angiotensin 1 to active angiotensin 2. We know ARBs which prevent binding of angiotensin 2 to angiotensin 1 receptor. We have a recent class which affects in the first pathway, which binds to renin and inhibit it. So they directly bind to renin and block it, so that even the angiotensin 1 cannot be formed from angiotensinogen. We have only one drug in place, aliskiren. Actually it is a renin inhibitor. You can see there is a clue in its name, renin inhibitor. So it's aliskiren, right? With regard to antihypertensive drug, antihypertensive therapy, the aliskiren is not used as first line, unlike ACE and ARBs. ACE inhibitors are first line in young patients, diabetes, congestive cardiac failure, CKD, MI. We prefer ACE inhibitors to be one of the first line antihypertensives. But similarly, if ACE inhibitors are not tolerated, you can choose ARBs, fine. But DRIs are not the first line. They are used only if the patients, after being given the conventional drugs, are unable to be, their BP is not controlled well, then you could consider this as add-on antihypertensive drug, mainly when in refractory and resistant cases. So with this, and one more important point is, never ever you have to have combination of these drugs in a patient. There should be never a patient receiving an ACE inhibitor with ARB or an ACE inhibitor with DRI or angiotensin receptor blocker with DRI. These are absolute no. They are contrary. This combination is absolutely not preferred. Because why? Yes, they all will increase potassium. So this will increase potassium, this will increase potassium, this will increase potassium. So when you are giving them combination, serious hyperkalemia that can immediately cause serious life-threatening arrhythmias, patients can die. So combination of any of these drugs is absolutely not preferred. An interesting association in the current disaster, pandemic disaster, is the SARS virus, right? The coronavirus, COVID-19 virus. It has been observed that it binds to A's in the pulmonary circulation and then it enters into the systemic circulation of the, it enters into the body of the human beings. So several physicians have raised concerns that using drugs with affect renin-angiotensin and ACE inhibitors or ARBs or DRIs, they are likely to increase the risk of infection by COVID-19. But almost all the major guidelines, they have uniformly said that at present there is no evidence that patients who are receiving any of these drugs are at have increased susceptibility to COVID-19 infection, and so please continue giving these drugs when there is indication. So this is the take home message as of, I already say, as of, today's date is 16th or 17th, whatever, 17th April 20, right? So this may change in due course, but as of now, there is no urgency for the physicians to stop giving any of the drugs affecting renin-angiotensin aldosterone axis for the increased risk of COVID-19. So with that, we complete ACE inhibitors and ARBs. A long session, but very important. All the important points, I think I have spelled it out. The next drug class that you may use in patients with hypertension are the alpha blockers. Alpha blockers, how many receptors do we have for alpha? Yes, like beta is classified into beta 1, beta 2. Alpha is classified into alpha 1 and alpha 2. Further, this alpha 1 is subclassified into alpha 1A, alpha 1B, alpha 1D. If you consider this is too much, forget. Not a highly relevant, but at least know that we have alpha 1 and alpha 2 types in alpha receptors. So when we say alpha blockers, these are the agents that are going to block alpha 1 and alpha 2 receptors. So we have certain drugs which block both alpha 1 and alpha 2, so they are non-selective, and we have selective alpha 1 receptors. They are only alpha 1, they don't block alpha 2 to that extent of non-selective blockers. Non-selective, phenoxybenzamine and phentolamine, not terribly important from your perspective because these are the drugs that will be used mainly in by specialists, but you need to keep these drugs in mind. Selective alpha 1 blockers, prazosin, doxazosine, terazosin, silodosin, silodosin, tamsulosin. So these are all selective alpha blockers. The non-selective, they are primarily preferred in patients to control hypertensive crisis in pheochromocytoma. This is a malignant condition of adrenal medulla cells. So in such patients, there is increased adrenaline in their circulation and they will have profound stimulation of alpha 1 receptor. So for them, the non-selective irreversible phenoxybenzamine is preferred. Even if you don't remember this indication, it's okay because you're not going to deal with such pheochromocytoma patients. But more importantly, the selective alpha-1 blockers, right? Alpha-1 blockers, prazosin, terazosin, doxazosin. You need to know this one in mind because the alpha-1 receptors, apart from present in the blood vessel, they're also located in the smooth muscles of bladder. So in patients, in male patients who have benign prostatic hyperplasia, where the prostate gland just below the bladder along the ureter, right? So when they are enlarged, they pose a pressure on the urethra and they will have decreased urine moving out from the bladder. So in such patients, if you are using alpha blocker, right, then you could relax the smooth muscles and that will facilitate the urine outflow. So in hypertensive patients who have benign prostatic hyperplasia, one of the preferred agents is selective alpha-1 blocker. But even then, this is used as add-on along with other drugs like calcium channel blocker, ACE inhibitors, ARBs. We will use this as an add-on for such patients. Similarly, you have patients who have peripheral vascular disease that we discussed earlier. Which drug class is contraindicated? Yes, beta blockers. So we don't prefer beta blockers in them, but alpha blockers are preferred because when they block alpha-1 receptors in the smooth muscles of the blood vessels, it can cause a vasodilatation, which is preferred in patients with PVD, peripheral vascular disease. So these are all some specific indications to initiate alpha-1, selective alpha-1 blockers, BPH and PVD. But when they block alpha-1 receptors, if you remember that picture we had where alpha-1 also mediates venous stone. So if they reduce alpha-1 supply to venous stone, then the veins will get enlarged, reduce preload, so that will reduce the blood flow to the arterial system, and that will reduce the blood flow to the brain, so that will result in orthostatic hypotension. And as like ACE inhibitors, you also have increased risk of first dose hypotension. So because of this, alpha blockers are not used as first line agents, not used as first line agents. Only in patients who have uncontrolled, in patients who have concomitant BPH, concomitant PVD, we may consider initiating alpha blockers. Another advantage of alpha blockers is it reduces the bad cholesterol. It reduces LDL, reduces triglycerides and increases the good cholesterol, increases HDL. So this is another advantage of using alpha blockers, right? So we completed alpha blockers and next we are going to discuss about dihydropyridine. DHP stands for dihydropyridine, calcium channel blockers. Calcium channel blockers, as their name suggests, these are the drugs which block the calcium channels in the smooth muscle. Assume this is the picture of a smooth muscle in the heart or smooth muscle in the blood vessel, wherever it be, right? So for this smooth muscle to undergo contraction, the first thing that we need to do is activate L type of calcium channel. So this channel is activated, it allows the entry of calcium and that calcium goes into the sarcoplasmic reticulum, which has lot of ionized calcium. It's an in-house store of ionized calcium. So this calcium goes there and it causes release of lot of ionized calcium, calcium mediated calcium release, calcium mediated calcium release. You must have been aware of this in physiology, right? So that ionized calcium will be released into the cytoplasm and that facilitates interaction between actin and myosin and that leads to increased contraction, increased tone of the blood vessels, increased heart rate, increased force of contraction in heart. Now, these are the drugs calcium channel blockers, we call it CCB, or calcium channel antagonist, CCA, anything is fine. So these are the drugs which are going to act on these calcium channels and block the entry. So they are going to reduce the calcium entry, so calcium won't be there, so they will facilitate relaxation. So they are going to be vasodilatation, and there is going to be decreased heart rate, and there is going to be decreased force of contraction in the heart, decreased force of contraction in the heart, right. Now, there are two subclasses of calcium channel blockers. One is called dihydropyridines, another one is non-dihydropyridines. There are some important differences in these class. This dihydropyridines block calcium channels, right, in the blood vessels. So their predominant effect is to reduce systemic vascular resistance. So dihydropyridines, they predominantly decrease systemic vascular resistance. This non-dihydropyridines, they predominantly, underline the word predominantly, okay, they predominantly act on the heart. So they act both on the conducting system, so they block the calcium entry and so they reduce the heart rate, and they also act on the contractile myocardium, so they reduce the force of contraction. As I told you, their predominant effect, but there will be some effect in the blood vessels, and that also will lead to reduced systemic vascular resistance. But dihydropyridine, their effect are strictly limited only to blood vessels. They do not act on the calcium channels in the heart. Non-dihydropyridines are predominant blockers of calcium channels in the heart, but to some extent they also block it in the blood vessels. So this is the basic difference that you need to know, so that now you know which one should you prefer it for hypertensive patients. Yes, for hypertensive patients, although both will logically reduce blood pressure. If you use dihydropyridines, it reduces systemic vascular resistance, reduction in blood pressure. If you use non-dihydropyridines, reduction in heart rate and force of contraction, so thereby reduce the cardiac output, so reduction in blood pressure. But in patients who do not have any other cardiac complications or tachyarrhythmias, we usually prefer only the dihydropyridine calcium channel blockers as anti-hypertensive drugs. This is, the non-dihydropyridines are reserved only for some specific tachyarrhythmic patients, or specific type of angina. We call it Prince medal angina. So for some specific indications, then only we prefer non-dihydropyridines. Otherwise, it is usually the dihydropyridines. So the drugs in the dihydropyridines, see, you can see pyridine, right? So they end with dipine, amlodipine, felodipine, nifedipine, nicardipine. So these are some of the drugs that are in the dihydropyridine category. If it is non-dihydropyridine, okay, you have a clue, they are non-dihydropyridine, which means they do not have dines in their name. So it is diltiazem, verapamil. It is important to remember the names of these drugs. At least you should know diltiazem, verapamil belongs to non-dihydropyridine, which predominantly acts on the heart, and all other dipines, they belong to dihydropyridines, which predominantly act on the blood vessels. So this is important for you to keep in mind. When you are using dihydropyridines, I told you they are predominantly going to act on the blood vessel, and they are going to reduce calcium entry, so they cause reduction in the vascular resistance. So when the vascular resistance is less, when you reduce the systemic vascular resistance, right, that sends a feedback through the baroreceptors and carotid receptors to the vasomotor area in the brain. There is always a feedback. When you have relaxation of blood vessels, that sends the baroreceptor stretch will be more, and that sends an impulse to the vasomotor center, and that increases the sympathetic discharge to the heart, and that will result in increased heart rate and increased force of contraction. Mainly increased heart rate will be observed. So this is referred to as reflex tachycardia. So this happens mainly with dihydropyridines because they relax the blood vessels profoundly. Within few minutes of administration, they dilate blood vessels largely, and that will stimulate this reflex, and that results in increased heart rate. This reflex tachycardia is not observed with two dihydropyridine drugs. One is amlodipine and the other one is felodipine. So these two dihydropyridine will not cause reflex tachycardia. We don't see increased heart rate because they are very long acting as well as they are very slow acting drugs. So they slowly get absorbed from the GIT and they slowly dilate blood vessels, so you don't observe this reflex tachycardia. Otherwise, with other dihydropyridines and particularly with a drug called nifedipine, which gets absorbed very fast because of its lipophilicity, and you get to observe this rise in heart rate very fast and profound. So this is one adverse effect that you need to keep in mind. Other commonly observed adverse effects with dihydropyridine calcium channel blockers, because it's one of the first line drugs that is most often prescribed that you will see in clinics. So that's why you need to be familiar with the common adverse effect profile of dihydropyridines. So other common adverse effects we will see is gingival hyperplasia. So there is increased growth of gingiva, gums, which is most often irreversible. Even if you stop, they won't regress. Surgery has to be done, right? Then it can result in not serious but ankle edema. Mostly this is observed in ladies. Their ankles, you get observed a swelling. So there is retention of fluid. Many a times when you are using a calcium channel blocker, if there are concurrent diuretics used because the patient is having, let's say, congestive cardiac failure or because of CKD, chronic kidney disease, right? So the diuretic will take care of this edema. Otherwise, if the diuretic is not there, this is going to be one of insignificant adverse effect that you have to counsel the patient on. Third, because of the vasodilatation, it can also cause flushing of the face, where the patient will feel heat, get irritated, right? So these are some of the common adverse effects that you observe with patients receiving dihydropyridine calcium channel blockers, which ends with dipine. As I told you, repetition will help you to keep in mind. So any drug that helps with dipine, amlodipine, commonly used drug, right? So these are the common adverse effects you need to keep in mind. Now, when will you initiate a dihydropyridine calcium channel blocker as an antihypertensive? What are the indications? The first important is in a patient who has what is shortly called as ISH, isolated systolic hypertension. In such patients, only the systolic is above 140 and the diastolic is perfectly normal. So such patients are considered to have isolated systolic hypertension. More commonly you get to see in elderly patients who have some sort of atherosclerotic calcified arterial stiffness that increases the systolic blood pressure, and they are also having increased retention of sodium. So calcium channel blockers are one of the preferred drugs, in fact one of first line drug in patients with ISH. Most commonly you get to observe this in elderly patients. Above 55 years of age, this is most likely to happen. Such patients can also be prescribed thiazides. We will be seeing it in a while because they are at they have increased ability to retain the sodium. So thiazides can also be useful in such patients with isolated systolic hypertension. And calcium channel blockers are also preferred in Black, African, Caribbean patients. So normally we don't stress about any racial difference in the therapeutic effect of drugs, but if you need to know that race is one variable that can affect the drug's response, it is this class of drugs. So dihydropyridine calcium channel blockers, they do very well. They control blood pressure very well in patients with Black African or African Caribbean patients. So that's why I stress this point. We have another dihydropyridine called nimodipine. This nimodipine has one specific indication. It is used in subarachnoid hemorrhage. It's too early for you to know about specific details of subarachnoid hemorrhage, but grossly, what I would tell you now is, assume this is the blood, these are the blood vessels that are supplying the brain, different parts of the brain, right? I'm decoding it as simple as possible, right? And patients with aneurysm, like a thin wall, abnormal wall which gets dilated, and even when there is a small rise in the blood pressure, such aneurysm will break and there will be bleeding, right? So when such patients have aneurysmal rupture, most commonly the blood will log into a space called subarachnoid space in their brain. So this subarachnoid hemorrhage, right, when the blood is leaking from this aneurysm, right, it poses a pressure on the surrounding vessels. So the surrounding blood vessels will undergo vasoconstriction. And when they undergo vasoconstriction, the area which is supplied by them, they won't receive the adequate blood. So in subarachnoid hemorrhage, because of the bleeding, there is going to be vasoconstriction, and this is going to further aggravate ischemia. Ischemia means reduced blood supply to the peripheral regions. So in such patients, if you give nimodipine, nimodipine is a cerebroselective vasodilator. So it preferably dilates the cerebral vessels. So it dilates these vessels and thereby it reduces the chances of ischemia. So that's why one specific indication for nimodipine is subarachnoid hemorrhage, to reduce the incidence of vasospastic ischemia. Another indication is patients with Raynaud's disease. Raynaud's disease is characterized by peripheral vasoconstriction. You could say in this is the normal region where the blood flow is maintained, but here you see they are all white because the blood vessels supplying these sites have undergone tremendous vasoconstriction. So because of the vasoconstriction, blood flow is not proper to these regions, and that's why it is pale. If it is left, they will have terrible pain, and if it is not attended properly, they may even have gangrene. So for such patients, again, one of the preferred drug is dihydropyridine calcium channel blockers. They dilate these blood vessels and they reperfuse these terminal digits. So with this, we complete the important points that you need to keep in mind for calcium channel blockers. The last in the class of drugs acting on the blood vessels are the directly acting vasodilators. These are the 4 drugs that are commonly used in this category. Hydralazine, we have seen it partially, right, in the congestive cardiac failure. Could you recollect? Yes, in the vasodilator, hydralazine with isosorbide dinitrate is one of the preferred vasodilator that reduces mortality in patients with CCF, right? All right. Apart from hydralazine, we have diazoxide, minoxidil, and sodium nitroprusside. So these two drugs, they share a common mechanism. So they are called potassium channel openers. And these two drugs, they share a common mechanism. They release nitric oxide. So both these will account for vasodilatation, decreased systemic vascular resistance, and thereby decreased blood pressure. Hydralazine. Hydralazine, as like alpha methyl dopa, as like labetalol, is safe in pregnancy. So it is one of the commonly used anti-hypertensive drug in a pregnant. Apart from pregnancy, it is not a very good antihypertensive in general, and we use it only as a last resort. So only when the blood pressure is not controlled with other commonly used drugs, then we can combine this in refractory or resistant hypertension. It is available both orally IV, so that you can use it either to control patients who do not have crisis through oral, and when patients who have crisis, you can even use it IV hydralazine. When you are starting hydralazine in a pregnant woman to control her blood pressure, you need to do two things. One is you need to monitor her CBC count, as well as you need to test anti-nuclear antibodies before starting as well as at serial intervals, because hydralazine is one drug that can cause lupus, drug induced lupus. So patients who show increased ANA titer, they should be stopped administering this hydralazine. So you should do monitoring with CBC and anti-nuclear antibody. So especially when patients develop lupus, they complain of symptoms similar to any other autoimmune disease like arthralgia, fever, continued malaise, like they will feel always tired, right? So such symptoms should prompt you to do this test, and when it is positive, please discontinue the drug. Another pharmacological phenomenon that I want to emphasize here is tachyphylaxis. Have you heard of this term before? All right. Tachy means rapid, right? Increased. Tachycardia is increased heart rate. So tachy means rapid. Phylaxis means tolerance. So let's say you start a patient on hydralazine alone as a standalone drug today. Let's assume you are starting the patient on 5 milligram today. After 2 days, you are checking the patient's blood pressure, it is controlled, it is under normal limits. You are happy, the patient is happy, good. You ask the patient to come back after 1 week. If you see, the blood pressure would have again gone higher. So you may have to increase the dose to 7.5 milligram. These are a hypothetical situation. I want you to understand the meaning of tachyphylaxis. Okay. So let's assume after 1 week, in just 1 week, the patient is failing to maintain the therapeutic effect at the same dose and needs higher doses. If you raise to 7.5 and ask the patient to come back after increasing the dose to 7.5 milligrams a day, you will find controlling of blood pressure. Then if you ask the patient to come back after 1 more week of increasing the dose to 7.5, you will find the patient's blood pressure is again more. So now you need to increase the dose to 10 milligrams. So the patient needs higher doses within short period of time, meaning the patient develops tolerance very rapidly, and you need to continuously increase the dose of the drug, and this is referred to as tachyphylaxis. Very uncommonly we get to see this. Only a handful of drugs do produce this tachyphylaxis. One drug is hydralazine. Another important point is hydralazine is metabolized in the liver by N-acetyl transferase. So this N-acetyl transferase in some individuals is very fast. So they immediately convert the hydralazine that is present in the circulation to inactive molecules. So such patients will have less active hydralazine in the blood and they will have less therapeutic effect of hydralazine. On the other hand, there will be few others in whom the N-acetyl transferase is slow. They will have more hydralazine in the blood because the enzyme metabolism rate is slow. So the more hydralazine will be there in the blood, and such patients will have greater reduction in the BP. So you need to know the acetylation status to find out whether there would be more or reduced blood pressure reduction. So these are all some important points regard to hydralazine, but the most important that you need to keep in mind is it's one of the preferred drug in a pregnant. It can lead to lupus and you need to find out ANA and CBC monitoring. The second vasodilator category of drugs are the potassium channel openers that includes diazoxide, minoxidil. Do you remember this picture again? Yes, the same one that we had it in congestive cardiac failure. So we have there dealt potassium channel categories of drug that these channels open the potassium channels on the blood vessels and that leads to hyperpolarization which inhibits the calcium channels. So less calcium entry, less contraction, vasodilatation. So this is how they reduced systemic vascular resistance and consequently decrease blood pressure. But they are not very good agents to be used as first line antihypertensives. They are very low in efficacy. That's why they are used only in patients who are unable to have a controlled blood pressure with other first line agents, combination of first line agents. Then you could give a try with these as an add-on therapy. Another interesting point with these potassium channel openers is this minoxidil particularly is when you apply topically in patients who have male pattern baldness, right? It causes vasodilatation in this region and it can promote growth of hair follicles and growth of hair. So it is another, it has got another important indication much more than using it in hypertensive patients like alopecia and male pattern baldness. This is minoxidil and here you use minoxidil topically as a solution, right? So these are important. The last vasodilator group drug is sodium nitroprusside. Sodium nitroprusside, as like a hydralazine, increases the release of nitric oxide that causes vasodilatation and reduction in systemic vascular resistance, reduction in blood pressure. The important points that you need to keep in mind is sodium nitroprusside is a very rapidly acting drug. If you start now, within 10 minutes you will see BP falling down. Available as intravenous. So we prefer it in patients who have hypertensive crisis. So if their systolic is 180 or above and or diastolic 110 and above, then their BP has to be brought down as immediately as possible. That is done with sodium nitroprusside. Other important points for sodium nitroprusside is, if you see, sodium nitroprusside is light sensitive. That is why even the vial that contains nitroprusside, it will be dark colored. And when you are giving it as infusion in patient for controlling the blood pressure, you should always close that infusion which contains the sodium nitroprusside with aluminum foil. If you fail to do this, then because it is light sensitive, it will be destroyed by the light and hardly any active sodium nitroprusside will enter into the systemic circulation to produce the therapeutic effect. So, at this point you need to keep in mind practically any solution that contains sodium nitroprusside is being infused should be covered with aluminum foil because it is light sensitive. Another point is the sodium nitroprusside in the body releases cyanide, and the cyanide causes cyanide toxicity by binding to the tissue cytochrome oxidase, by binding to the hemoglobin, right. So, in patients who have more sodium nitroprusside being administered, they are more likely to develop cyanide toxicity. In such patients, you need to prophylactically give an antidote, cyanide antidote. Nowadays, we have oral antidote called sulfanagen sodium. You can give 1 hour before you anticipate that toxicity. Or you have a parenteral drug called sodium thiosulfate. If you give this parenterally, it will bind to cyanide and it will excrete it in the urine. So, these are the antidotes that you need to keep in mind in case a patient who is receiving sodium nitroprusside lands up in cyanide toxicity. So, with this, we complete the category of vasodilators, and the last antihypertensive drug class are the diuretics. Same picture that we had it before for congestive heart failure. So, diuretics, they are the drugs acting on the nephrons in different segments, and they predominantly reduce the sodium and the water retention, and thereby they reduce the blood volume. In the congestive heart failure, we mainly focused on loop diuretics, which acts on the thick ascending loop of Henle, sodium potassium 2-chloride transporter. In antihypertensive, we are going to focus more upon another drug diuretic class which acts on the distal convoluted tubule, which is thiazides. So, the thiazides will act on the distal convoluted tubule and prevent reabsorption of sodium, and thereby it reduces water reabsorption. So, when both of this is reduced, you will expect reduction in the intravascular volume. So, that will reduce preload, that will reduce cardiac output, that will reduce blood pressure. So, this is how it acts. In the thiazides, we have chlorthalidone hydrochlorothiazide. These are commonly used antihypertensive drugs, but I want you to remember at least chlorthalidone, because chlorthalidone is a longer acting thiazide which has half-life of around 60 hours, which means that approximately 2 to 3 days it has, and it maintains the blood pressure throughout the day and night very well. So, that is why this is important. Thiazides, initially they act on the nephrons and they reduce the sodium and water reabsorption, reduce cardiac output, reduce blood pressure. But what happens after chronic use of thiazides is, because the sodium content of the body itself is less will be the sodium inside the smooth muscles of the blood vessel, and less will be the vascular tone, and less will be the total peripheral resistance. So, thiazides have this unique phenomenon of reducing the sodium entry directly into this blood vessel, and that contributes to reduce systemic vascular resistance, and that again contributes to its antihypertensive effect. But only thing is, this won't happen immediately, this will take a while, at least 2 months to happen. Immediately its effect on the kidneys that contributes to its antihypertensive effect. Thiazides are, if you see its adverse effect, as like loop, it reduces the sodium in the blood. So, hyponatremia, hypokalemia, hypomagnesemia, but it increases calcium. So, it results in hypercalcemia, very important point. In fact, the only diuretic that causes hypercalcemia is thiazides. All other diuretics cause hypocalcemia. Thiazides are the only ones that raises calcium content in the blood, hypercalcemia. Thiazides also increase the uric acid. Thiazides also increase glucose and LDL. So what is the clinical significance of this? So thiazides can be preferred in patients with isolated systolic hypertension, because if you remember in the calcium channel blocker we said those patients will have increased salt sensitivity. So they will have increased retention of sodium. So thiazides, because of its reduction in the sodium, it could be one of the preferred agents in ISH. That's good. Second important point is, because it causes hypercalcemia in women who have osteoporosis, right? Increased calcium will benefit their bone condition. So if you have a hypertensive women with concomitant osteoporosis, thiazides are again preferred drug because of this hypercalcemia. What are the other clinical important points for these two? If you have a patient with gout, because thiazides raise uric acid, you would not prefer it. Similarly, if you have a patient with diabetes mellitus, because thiazides raise glucose, you would not prefer it. So these are all the clinical points that you need to keep in mind of to when to start and when not to give, and what are the things to monitor while thiazides is being given. The other diuretic that may also be used in patients with hypertension are the loop diuretics. Furosemide, we have seen its use in congestive cardiac failure. Of course, if you have a patient with hypertension and CCF, yes, loop diuretics are preferred. But if you have a patient, let's say chronic renal failure patient, right, for whom we have put thiazides along with ACE inhibitors. ACE inhibitors are the first line, and along with that thiazides are there. Now when such patients have their glomerular filtration rate falling less than 30 ml per minute, thiazides are not to be administered, because thiazides will not be effective in such low GFR values. So for such patients, loop diuretics will replace thiazides. So these are the indications for loop diuretics as antihypertensives. Otherwise, they are very weak compared to thiazides. So these are all the essential points that you need to keep in mind with each of the antihypertensive drug class. Centrally acting includes clonidine, which is for resistant because of lot of side effects, methyl dopa for pregnancy. You need to monitor liver function test, and you should not give iron preparations along with alpha methyl dopa. Reserpine obtained from plant source, again preferred for patients as an add-on in refractory or resistant cases, not used as a first line because of suicidal tendencies, extrapyramidal side effects. Beta blockers, we have selective, non-selective. Labetalol is preferred for pregnant. Nebivolol for PVD, peripheral vascular disease with hypertension. And before giving any hypertension, beta blockers, rule out bronchial asthma, chronic obstructive pulmonary airway disease, and is not also preferred in patients with diabetes. And beta blockers should not be administered if patients do not have any other comorbid diseases. So they are preferred only if hypertensive patients have congestive cardiac failure or MI, right? ACE inhibitors, ARBs. ACE inhibitors are wonderful class of antihypertensive drugs that are preferable in patients less than 55 years of age, patients who have diabetes, congestive cardiac failure, MI, and chronic renal disease. ACE inhibitors, adverse effects you need to keep in mind, and if patients are unable to tolerate dry cough, then only ARBs will come into picture. ACE inhibitors increase bradykinin level, that is good in terms of additional antihypertensive effect, but at the same time causes dry cough. Alpha blockers, they are preferred mainly in patients with benign prostatic hyperplasia as well as in patients with peripheral vascular disease. Selective alpha blockers are important. Calcium channel blockers, we have dihydropyridine, we have non-dihydropyridine. Dihydropyridines are more selective to blood vessels and non-dihydropyridines are more selective to heart. Of course, they also have little activity on the blood vessels. Dihydropyridines are preferred for isolated systolic hypertension. Nimodipine finds its use in subarachnoid hemorrhage, and in general they are preferred also for Raynaud's disease. Gingival hyperplasia, edema in the foot, right, and flushing of the face are some important adverse effects. Reflex tachycardia, you should keep in mind. Diuretics, thiazides are the important ones which have a role in especially patients with postmenopausal osteoporosis and isolated systolic hypertension. In patients with CKD, when the GFR is less than 30, thiazides can be replaced by loop diuretics. So these are some of the important essential points, and whatever we discussed has been summated here as the key first line agents, right? Whatever I discussed right now. So you can go through it, and yes, I need to focus here. Sometimes, or most often the case will be, you start them on first line antihypertensive drugs, but eventually their blood pressure will not be controlled with one drug. So they may need combination, they may need add-on drug. So here, what you should focus is at least those which are in solid green lines. So these are the combinations which have been shown to be useful and acceptable. So let's say you have started a patient on ACE inhibitors, right? And then after 6 months, the BP reduction is not satisfactory, and you have gone to the maximal dose of the ACE inhibitor. Now you want to add another drug to it. Then you should not choose a beta blocker. You should not choose angiotensin receptor blocker, but you could choose either a calcium channel blocker or a thiazide. Similar goes with the ARB. If you have started them on ARB and if they are unable to achieve the desired goal, target blood pressure with the maximum dose, go for addition of either a thiazide or a CCB. Similarly, if you have started a patient on CCB, gone to the maximum dose, did not have any target BP, go for addition of either ACE inhibitors or ARB. Don't go for, you can see it's a dotted line, don't go for beta blockers with calcium channel antagonists. It can reduce, but the amount of reduction in the blood pressure and the time it takes will be much longer. So better to choose only these. So only remember the solid groups, that I think will help you in adding the drugs rationally. Now I want you to be just familiar with the two terms. One is resistant hypertension, other is refractory hypertension. What does resistant hypertension mean? So if the blood pressure in a patient is not controlled with at least 3 different classes of antihypertensive drugs, including a diuretic, at their maximal doses, then you are going to call such patients as patients with resistant hypertension. For such patients, obviously, the treatment will be referred to a specialist. So it's going to be the cardiologist who is going to look after all this. You don't have to be knowing in details of how to manage, but such patients are likely to have aldosterone excess that contributes to increased retention of sodium water that keeps their BP high. So spironolactone addition could be beneficial in such patients. Another term is refractory, which means even after receiving 5 antihypertensive drugs, their BP is not under control. Such patients are referred to as refractory patients. Again, such patients will be treated by the specialist. They will have a combination of various other drugs like aliskiren, reserpine, clonidine, and then you don't have to know much. In pregnancy, yes. So whatever we discussed is listed over here. The safe drugs, the unsafe drugs which are contraindicated, labetalol, hydrazine, alpha-methyl dopa are the preferred drugs in pregnancy. Lastly, hypertensive crisis. How do we define hypertensive crisis? So it is elevation of systolic above 180 with or diastolic above 110 millimeters mercury. So when patients present with such high BP, either they may not have any evidence of target end organ damage, in which case we use the word urgency. If they do not have any evidence of target end organ damage like myocardial infarction, retinal detachment, stroke, aortic dissection, these are all some of the commonly observed target end organ damage. If they don't have any such, then that entity is referred to as hypertensive urgency, and if they have any such target end organ damage, it is referred to as hypertensive emergency. Emergency means the situation is very bad, you need to control their blood pressure within few minutes to hours. Urgency means the situation is not that bad, of course it is serious, you need to reduce the blood pressure, but it can take a few hours to a day. So this is what the difference between hypertensive emergency and an urgency is, based on target organ damage and how soon you need blood pressure to be under control. These are some of the parenteral drugs. Always remember, in hypertensive emergency, you need to prefer drugs which are administered IV. There are subtle differences in choosing each drug for depending on what emergency is it. It's MI, you prefer esmolol. If it is dissection, you prefer. So there are subtle differences, but at your level you don't have to know. At least know the concept that for hypertensive emergencies you need to prefer a parenteral drug, IV drug, and this is list of some IV anti-hypertensive